Good evening, everybody.
Yeah.
I first thank the organizers, Dr. Sarana Kumar sir, Dr. Srinath sir, and Rajguru sir, and his team for giving me the opportunity to present to the PGs. I can assure you that this is not going to be a very boring session, and let us have it a pleasant learning experience. So the topic is the magic band POCUS in India. So the objectives of the session today is to recall the basics of POCUS and its pitfalls, artificial intelligence in POCUS, and special situations where POCUS is used and a few case studies. Let's go into the basics of ultrasound, just revising. We have to be certain about the correct probe should be identified and used for the appropriate image scanning, and patient should be correctly placed, machine should be ergonomically placed, and three things that are important for image acquisition and optimization is the gain, the depth adjustment, and the brightness adjustment. Interpretation of artifacts is also important, as we see that there can be reverberation artifact or mirror imaging that can interfere with our interpretation of the images. A brief into the types of transducers, so linear, curvilinear, and the array probes. Linear probe has a linear footprint, so this is a rectangular footprint, and it is used for superficial structures like musculoskeletal, eyes, breast, testicles, pleura, veins, for imaging the vessels, etc. The next one is the curvilinear probe. So it is curved. So this is convex shaped footprint, which can image the deeper structures like the gallbladder, kidney, and liver, and so on. Next is the echo probe, which has a conical footprint, and it is used to scan the heart, lungs, pleura, and abdomen. So here we can see that there is an inverse relationship between the frequency of probe and the imaging depth or the penetration. So as the frequency is reducing, the depth is as the frequency is increasing, the depth is reducing, and vice versa. So how do you define POCUS? So it is the sonography that is performed and interpreted by the clinician at the bedside, and it is the focused goal-directed examination. So eFAST, as you all know or aware of the 6 areas where we focus. So first is the pericardial scanning, area of right upper quadrant, left upper quadrant, the suprapubic area, and the right anterior thoracic and the left anterior thoracic. So we interpret the findings as from the right upper quadrant, it is the hepatorenal interface labeled as RUQ. LUQ, we focus on the splenorenal interface. In the pelvis, the pouch of Douglas, interpreted as labeled pelvis. In the pericardium, it is the xiphoid, subxiphoid area or the parasternal area. It is labeled as pericard, and right and the left chest, where the longitudinal anterior view, plain anterior view, or the longitudinal plane left-sided anterior view, labeled as right and the left chest. So going on to the broad application of POCUS, in the imaging of heart, we can find out the left ventricular function, hypertrophy, wall motion abnormalities, and the pericardial fluid. With relation to the lung, we can find out whether the patient has pulmonary edema, pneumonia, pneumothorax, refractures, or COPD or asthma. With regard to antenatal women, we can find out if it is ectopic pregnancy, detect the age, whether there is bleeding, and also the fetal position can be identified. With regard to abdomen scan, we can find out whether it is hydronephrosis or epididymoarthritis or orchitis, torsion or polylithiasis or cholangitis, polycystitis, appendicitis or intussusception. And with regard to MSK, for the soft tissue abscess, tissue infection, and foreign bodies can be detected, tendon injuries, effusion, shoulder dislocation, or with vascular, we can also do the screening of abdominal aortic aneurysms and carotid media thickening can be done. DVT and peripheral vascular access can also be done. DVT can be diagnosed, screened. So what are the pitfalls in POCUS? We see that there is an observer variance. So there is a variance when the same person is going to do the scan the next time. We see that that's a variance with regard to the same observer. And also there is an inter-observer variance where the image by the two persons may not be the same. And in order to have a standardized technique and image, we have to train the postgraduates to be doing the proper technique and the way of interpretation. So what is more important is the clinical correlation and the correlation between the clinical presentation and the POCUS image. A few conditions where the clinical correlation is more important and standardized learning of a few points, it can bring a difference in the diagnosis of patient. So here we see that there is fluid collection around the heart, and we see that this is a descending aorta, and here we have the collection which is present anterior to the aorta. And in this image also we see that this is the aorta and the collection here is above the aorta. So this is the pericardial collection. Now we come to the third image where this is the descending aorta and the collection is seen posterior to the aorta. So this is the pleural effusion. So here is the pericardium and this is the pleural lining. So we have to be very careful in identifying the pericardial and the pleural effusions. So how to identify pericardial effusion versus ascites? So this is the falciform ligament, and this is the scanning from the skin. We see that there is a collection close to the skin. So this is the ascitic collection. So the fat collection can be misinterpreted as fluid. So as we see here, there is a there is an echogenic, mixed echogenic area which is present within the pericardium, and this is the fat layer that is present. This is the epicardial fat, and the arrow above, the arrow that is there is the pericardium, and there is another fat collection which is there above the pericardium. This is the mediastinal fat. So we have to be very careful in identifying the epicardial fat and not interpreting it as a fluid collection around the heart, which can lead to disastrous interventions and death of the patient. So we have to be very careful. Here we have another artifact where there is mirror imaging of the liver. So this area also shows structure, solid structure. So this is not so. It is just the artifact that is produced by the liver. And here we see that there is a air bronchogram which is present and fluid collection around the area. So we may misinterpret it as a pleural effusion, but here it could be just a reactive pleural fluid that is present secondary to the consolidation that is in the lungs. Going on to the ultrasound. Role of ultrasound or POCUS in special situations, we can find out whether the endotracheal tube is correctly placed, and Ryle's tube placement can be confirmed. And in hypotensive emergencies, the IV access, peripheral access, and the central access can be done. Gastric ultrasound we can use to find out the gastric volume, and airway ultrasound we can also find out where is the cricothyroid membrane to go for emergency cricothyroidectomy. Abdominal ultrasound, we can differentiate the various abdominal emergencies with which the patient can present, ranging from cholecystitis, polylithiasis, pancreatitis to gynecological emergencies like twisted ovarian cyst. And it is also used for administering on-arrival blocks for pain relief in trauma patients. Vascular ultrasound, as we have already mentioned, the peripheral venous access, central venous access, and for detecting DVT in peripheral veins. Airway ultrasound is used for locating the cricothyroid membrane, confirmation of position of tubes, endotracheal tube and the right tube position. And here you can see that this is the gastric shadow, which you can see, and this is the right tube that is present in the stomach. The gastric tube that is there, the right tube. And here we have the stomach image, which has internal echoes or the starry appearance because of the air bubbles and the fluid content producing the mixed echoes. Here is the airway anatomy. The picture at 3 levels is denoted here. We see that there is a hyper-echoic lesion or structure. Compared to the opposite side, it is more hyper-echoic. So this is at this level, as you can see, and it is could be the laryngeal edema that can be present. So this is the tissue that is edematous, which is giving the increased echogenicity of the shadow, increased echogenicity of the ultrasound beam. Role of artificial intelligence in POCUS. So before going into the detail, what we can see is that what is artificial intelligence is when the machine is able to think like human being, we consider it as artificial intelligence in layman's words. So how artificial intelligence is helping us in machine learning. So machine learning is when the machine is helping us to perform a procedure or helping us to learn a few points. So how it does is first process in artificial intelligence in all these processes is data mining, where the machine is able to collect the data, edit the data and process it. The second step is actually the deep learning process assisted by the artificial intelligence. Now the artificial intelligence will be guiding us in locating, positioning the probe and in locating the images and how we can optimize it and doing the auto adjustment of the ultrasound machine and also nullifying the artifacts. So by this process, the image is optimized and in next level, in deep learning, there is the next level where there is a feedback loop where the artificial intelligence is telling you that this is the diagnosis, and by altering the few images, it will be asking you what is the diagnosis, and by this way, it is helping in the learning process. So the POCUS, artificial intelligence in POCUS, thus improves the accuracy and efficiency of evaluation. For example, in auto-calculating IVC collapsibility, it is very helpful. And the most difficult left ventricular outflow tract velocity time integral, which has a manual calculation which cannot be done so easily, is done instantaneously by the AI incorporated POCUS. And the quality assurance for patient care standards is maintained by this. Next, we have the automated deep learning based systems which are incorporated. So these automated training models help to teach the novice PGs also. Here, there is an image of gallbladder thickening. So this is also helps in differentiating the various causes of pain in the right hypochondrium. So whether it is caused by the inflammation of the gallbladder or because of the sludge or because of the stones that are present, polylithiasis, or because of or is there any obstruction or polyp, all those can be identified by the ultrasound. Now we'll go to the last part, the discussion of cases. These cases are actually picked up from our center, and the first case is a 50-year-old male presented to the ER with history of fall 15 feet. On primary survey, we see that patient is conscious with patent airway and having a saturation of 95% with reduced air entry on the right side. Circulation was showing pulse rate of, patient has a pulse rate of 123. GCS is normal, 15 by 15, and on eFAST we found that there is barcode sign suggestive of right hemithorax. In the right hemithorax, suggestive of right-sided pneumothorax. So ICD was inserted and the patient was discharged well. So we see absent sliding sign. So the sliding sign is not there. This is the barcode sign that you can see. So next, we go to the next case. So the next case, as you see, is a 30-year-old male who's brought to the ER with history of RTA, two-wheeler hitting a four-wheeler, and on primary survey, the patient is conscious, breathing is normal, and circulation, we see that pulse rate is 103. There is sinus tachycardia, CBG is 213. On secondary survey, we see that the patient has laceration over the left parietal region, and eFAST is positive for this patient in the right upper quadrant and left upper quadrant. There is the eFAST is positive with no air under the diaphragm. And the CT turned out to show that there is a grade 4 splenic injury. Emergency splenectomy was done and the patient was discharged. So this shows the free fluid in the Morrison pouch in this patient. The third case scenario is that of a 19-year-old male who was brought to the ER with a history of assault with a sharp-edged object on the right side of chest. On primary survey, airway was patent and the patient was breathing spontaneously with a saturation of 94% in room air, and circulation, the heart rate was 118 per minute. There was sinus tachycardia, laceration over the chest was there. eFAST showed positive spine sign suggesting hemothorax, right hemithorax in the right side. There was hemothorax and ICD was inserted. This patient is also doing well, and this video shows the spine sign positive. Going on to the next case scenario, this is a 25-year-old female complaining of abdominal pain for 5 hours, airway patent, cervical spine stable, breathing, respiratory rate is slightly rate increase, 30 per minute, 96% in room air is saturation, tachycardia with a heart rate of 106, BP was 90/60, and UPT was negative. eFAST, there was no free fluid in the abdomen, USG emergency POCUS done, showed right, suspected right ovarian torsion. In view of the hemodynamic instability that occurred soon, patient was intubated and patient was shifted for emergency laparotomy. Intra, there was ovarian torsion. So this person also did well. So as such, POCUS is a physiological study with a on-spot clinical, it is used as an on-spot clinical decision tool, but it is an extension of the clinical examination, and it is a safe and repeatable tool with the expanding horizon. So thank you all for the patient listening, and again I thank the organizers for the opportunity, and it is wonderful to meet the PDs. So you are welcome to raise your queries if any.